Hello, thank you for joining us, and thank you to the organizer of Critical Care Canada Forum for the kind invitation. Together, we're going to review what's new in airway management in 2023. I do not have any conflict of interest to disclose pertaining to this topic. In the next 20 minutes or so, we're going to review the new information that we've gathered in the past year as it comes to epidemiology of airway management, the devices and techniques, the recommendations, and then we're going to summarize everything and highlight the take-home messages. Epidemiology. We have learned that airway management in the critically ill patient is accompanied by a significant number of complications. And recently, the group led by Jessica Downing has analyzed the prevalence of perintubation major adverse events among critically ill patients in this systematic review and meta-analysis. And what they found by assessing 44 articles and over 34,000 intubations is that peri-intubation major adverse events are in fact common, as we were expecting. They were identified in over 30% of all intubations. And that accounts for almost 1 in 3 patients intubated outside the operating room or the recovery room experiencing serious adverse events. In the second part of the year, Lee and Lighthall analyzed the factors associated with 30 and 90-day mortality in intubations among critically ill patients in these publications in Acta Anesthesiologica Scandinavica. It's a retrospective analysis of data collected prospectively as part of our quality improvement project. And what they found is that 30-day mortality in multivariable analysis was associated with cardiac arrest as the indication for intubation, hypoxia as the indication for intubation, need to perform the intubation in the intensive care unit. And what is interesting to note is that the presence of a supervisor reduced the risk of mortality at 30 days. So having expertise directly present at the time of intubation seemed to have a protective effect against adverse outcomes. How do we put this data into context? We have seen back in 2021 the publication of the INTUBE study, and that highlighted how in this very large multi-center prospective study that overall the incidence of peri-intubation adverse events is quite high, 45%, and cardiovascular instability seems to be the most common adverse event, followed by severe hypoxia and cardiac arrest. And it seems that experiencing a major adverse event at the time of intubation correlates then with mortality rate down the line. What new information did we obtain this year as it pertains to devices and techniques? Many of you may be already familiar with the device trial published in the New England Journal of Medicine by Pracker and colleagues. This study compared video versus direct laryngoscopy for tracheal intubation of critically ill adults. And you'll hear that examined in detail in one of the sessions at the upcoming CCCF meeting. This is a multi-center randomized trial conducted at 17 emergency departments and intensive care units, and patients were randomly assigned to undergo tracheal intubation to video laryngoscopy or direct laryngoscopy. The primary outcome being successful intubation on the first attempt. Now we know that this is a relevant primary outcome because the higher the number of intubation attempts, the higher the risk of experiencing major adverse events peri-intubation. The trial was stopped early for efficacy at the time of the single pre-planned interim analysis. And as you can see from this graph, video laryngoscopy showed to provide superior first pass success at intubation, and with 85% cumulative incidence as compared to 70% in the direct laryngoscope group. As we look at the characteristic of the operator, the intubation procedure, I would highlight that over 70% of intubation in each group were performed by resident physicians, followed by fellow physicians, and then by attending physicians. The specialty represented were emergency medicine for 70% of the intubation and critical care medicine for 25% of the intubation. 2 to 3% were performed by anesthesiologists. In terms of the device chosen for video laryngoscopy, the vast majority of cases were performed with a standard geometry blade, and less than 100 intubations were performed with a hyperangulated blade, probably reflecting the prevalence of the standard geometry blade as the first device of choice for many providers. Table 3 highlights some exploratory outcomes. I will briefly mention two of them. One is the successful intubation on the first attempt without occurrence of a severe complication. And that was occurring in almost 69% of patients in the video laryngoscopy group and in 59% in the direct laryngoscopy group. The other item that I want to highlight in this table is the incidence of esophageal intubation. So approximately 1% of cases still saw esophageal intubation. And we must not forget that this still occurs in real practice. And I'll refer to the Project for Universal Management of the Airway guidelines on preventing esophageal intubation, in particularly to their recommendation on using capnography as the gold standard to confirm proper endotracheal tube positioning. There is a lot of information in the device trial, including in the supplementary appendix. One on the left part of the slide, you see the subgroup analysis, and overall video laryngoscopy performs better than direct laryngoscopy in all the subgroup analysis evidenced here. And what I find also interesting is that the operator's number of previous intubations has a correlation with the successful intubation on the first attempt, and proficiency is reached faster with video laryngoscopy. That is, you need a shorter number of previous intubations to achieve a high success rate with intubation when you're using a video laryngoscope compared to when you're using a direct laryngoscope. If we look a few years back, there was a nice publication by Cortellazzi and Caldiroli and colleagues who looked at defining and developing the expertise in tracheal intubation using a glide scope for anesthesiologists with expertise already in direct Macintosh laryngoscopy. And what they notice is that the probability of optimal intubation increases with experience and reaches approximately 90% probability of optimal intubation after around 75 intubations with a glide scope also. What is important to note is that the curve continues to grow after that. So experience is important. Gaining familiarity with video laryngoscopy, even though the learning curve is shorter probably than with direct laryngoscopy, still putting an effort into learning proper video laryngoscopy techniques can have a significant impact in patient outcomes. We have seen in recent years the debate on using bougie versus stylet as an adjunct for tracheal intubation in critically ill. Seitz and colleagues in this publication in the American Journal of Respiratory and Critical Care Medicine try to explore whether individualized treatment effects in this context could be identified. And in a secondary analysis of the recently published randomized trial, they were able to identify patients for whom interaction between baseline characteristics and other consideration resulted in apparent benefit for either using a bougie versus a stylet. So that it might be possible to personalize care, and there are many characteristics that could account here for the appropriate selection of the device. We can see that in some circumstances, bougie might be the preferred choice. In others, a stylet might be preferable. Previous experience with the bougie plays a significant role. The NEAR registry has looked at extraglottic device use during emergency airway management as a rescue device. And they found that overall, the need to use a supraglottic airway device is rare. In this setting, approximately 56 encounters of airway management out of the over 19,000 patients analyzed. What is important to highlight is that when it was necessary to use a supraglottic airway, that led to favorable airway management outcomes. reinforcing again the concept that this is a very useful rescue device in situations where we cannot intubate and we cannot ventilate with face mask. And the characteristics that led to the use of supraglottic airway device, interestingly, were often the impression of a difficult airway before intubation. So we can prepare for that. And as we can see from table 3, the outcomes when an extraglottic device was utilized were very good. Again, another publication from the NEAR registry, this time on the incidence of rescue surgical airways after attempted orotracheal intubation in the emergency department. Over 19,000 subjects at an age of 14 years or above. In this cohort, the need for a rescue surgical airway was identified in 49 patients. The success rate was pretty high. In fact, in 44 out of the 49 cases, a surgical airway was successfully placed at the first attempt. So that represents approximately 90% of all. The total number of airway attempts prior to getting the surgical airway inserted correlates with the incidence of cardiac arrest during airway management, potentially. What do we have in terms of recommendations? The Society for Critical Care Medicine released clinical practice guidelines on the conduct of rapid sequence intubation in the critically ill adult patient. And they set out the goal of developing evidence-based recommendations in this context, both in terms of pharmacological and non-pharmacological management of rapid sequence induction. And their recommendations are summarized in this table. We have 10 recommendations. Number 1, positioning of the patient using a semi-Fowler position, that is with the head and the torso inclined. So head up, it's a recommended positioning. Pre-oxygenation is recommended with high-flow nasal oxygen delivery when laryngoscopy is expected to be challenging, and when the patient presents with severe hypoxemia with a PF ratio below 150, they suggest pre-oxygenating with non-invasive positive pressure ventilation. Sometimes it might be necessary to use medication-assisted pre-oxygenation to improve pre-oxygenation in patients undergoing RSI who are not able to tolerate the presence of a face mask, non-invasive positive pressure ventilation, or high-flow nasal cannulas because of agitation, delirium, or combative behavior. They advise to decompress with an nasogastric tube when the benefit outweighs the risks in patients who are undergoing RSI and are at high risk of regurgitation of gastric contents. They highlight that there is insufficient evidence at present to recommend whether there is a difference in peri-intubation hypotension or cardiac arrest if you administer peri-intubation vasopressors or IV fluids for critically patients who are on hypotensive before undergoing RSI. If you're using an induction agent in this context, there is no difference between etomidate and induction agents with respect to incidence of mortality or hypotension or vasopressor use in the peri-intubation period. However, we've seen from a secondary study of the INTUBE that propofol was significantly associated with a higher incidence of adverse cardiovascular events at the time of intubation. The SCCM recommendation advise against routinely using corticosteroids following RSI with etomidate for the sole purpose of counteracting etomidate-induced adrenal suppression. That's not something they suggest we need to worry about. What they strongly recommend is to administer a neuromuscular blocking agent when a sedative hypnotic induction agent is used for intubation. That has been shown to improve intubating conditions and facilitate appropriate delivery of the tube without adverse events. And in terms of the neuromuscular blocking agent selection, either rocuronium or succinylcholine should be used, and provided that there are no contraindications to the utilization of succinylcholine. So in summary, what we have seen in 2023 is that airway management in critically ill patients continues to carry a high rate of complications, so we need to be alert for this high-risk procedure. Video laryngoscopy improves first-pass success rates, training in the technique is still required. We should make an effort to optimize our technique in these regards. There is no one-size-fits-all regarding the choice between a bougie and a stylet for orotracheal intubation in critically ill patients. Appropriate selection should consider patient characteristics and operator's experience. Supraglottic airways are infrequently used as rescue devices in airway management for critically ill patients. However, when needed, they are highly successful, so we should always keep them in mind in our algorithm for management of the airway in the critically ill patients. Emergency front of the neck access, the emergent surgical airway may be required. Be prepared and do not delay if indicated. Consider appropriate optimization, hemodynamic support, and pre-oxygenation prior to intubation attempts may reduce the risk of adverse events, and awake intubation may contribute to risk reduction in this setting. And if choosing to perform airway management after induction of anesthesia, neuromuscular blocking agents improve intubating conditions and success rate, so do consider them. And with that, we come to a close, and I thank you for your attention. Here are my contacts. Please feel free to connect with me should you have any questions or would like to discuss this further. Thank you.